All right, so this is our last and final section of epidemiology. I know you guys are so sad. This is coming to an end. It was brief, but it burned so bright. The last section we're going to look at is helping to improve some of the decisions we can make in clinical medicine. So finally getting to the kind of the crux of this clinical epidemiology, how we can apply it back to our patients and making better decisions on their behalf. And so we'll talk a little bit about Bayes' theorem. We've kind of mentioned this before, but we'll kind of go over this again and how it can be related back to things like community screening programs. We'll look at individual patient care concerns, and then we'll look at decisions or kind of how we make decision trees, how we can use prior information to make better decisions on our patients and moving forward. And then we'll talk a little bit about meta-analyses and how we can utilize those to help us kind of to synthesize all the information that's out there about a subject and kind of coalesce it into usable information. So there's going to be, and this has already been happening, what's going to happen even further when you guys get out there and into practice is that there's going to be an increasing demand for this clinical decision to be based on the best available clinical research, right? So just because you think that, hey, this drug probably works because I've seen it work in a couple of my patients, doesn't mean that's always going to be the best medicine, right? We want to make sure that we're utilizing the best research possible to make the best decision for our patient. So on average, what is going to be the best treatment for this patient, right? So you can kind of use things like your anecdotal information and incorporate that in, but really you need to be using the best research-based medicines you can. So
laughter was the best medicine.
Laughter oftentimes is the best medicine unless you're crying on the inside, and then you have to. It gets complicated. That would be in Clin Pharm too. Don't worry. We'll talk about all of our psych meds there.
Lots of confounders there.
Yeah, oftentimes Xanax can be the best medicine. It just depends on what's going on. Anywho. So evidence-based medicine. So what does evidence-based medicine mean to you guys? To just have evidence to back you up. Okay, good. So having information that's peer-reviewed, right? Because what does that help us to do? Sure. So it can help to identify studies that might be kind of erroneous or might have too much bias in it, right? So that's kind of the idea. So hopefully you're having good information being published out there, well-designed studies that actually shows reliable information. Again, because we can't always detect how valid the information is going to be, but synthesizing all of that into helping us to make better decisions on the way we treat patients. And so this is including accessing the most relevant research data, so finding the most recent studies that have been published out there. Do you guys know, have you ever heard the statistic of how long it takes from something to be put out in the primary literature and the time it takes to actually get ingrained into clinical practice?
20 years.
Yeah, something like 17, 20 years before it actually occurs, right? So
it's only like a tiny percentage of the research that we put out.
Exactly, yeah. So even though you do all this research, you may think, I have a really good paper, I published on this thing. It could mean nothing in 10 to 15 years, right? Unfortunate, but it's kind of the way that medicine and the way that science works. So it takes a long time for things to really be ingrained, and so before it ends up in a textbook, it takes a while for this stuff to occur. And things need to be replicated, things need to be validated in large patient sets to make sure that it's actually true. You need to figure out which studies are going to be most trustworthy, which ones are going to be most applicable to your patients, and then try to use the appropriate methods to determine what's going to be the best diagnostic and therapeutic approaches based on that. So certainly there's no controversy about needing to improve clinical decision making and helping to maximize the quality of care. Oftentimes we're going to be looking at things to help us maximize the efficiency of the care we provide as well. Make sure we're doing things in a cost-effective manner, since everyone's kind of feeling that crunch as reimbursement and things like that get more and more stringent. So we're looking at some, there's always going to be difference in opinion regarding extent to which tools can help to make clinical decisions a little bit better. But in a lot of cases, you're going to see that both individuals and also large medical centers will have a lot of these things in place to help you make better decisions for your patients, right? So in a lot of cases, like say over at Nemours, a lot of our especially in the emergency department specifically, they have clinical pathways, right? So say, okay, your patient presents with these symptoms, here are the diagnostic tests you're going to run based on that, and based on how these tests come back, here's how you're going to be treating them, right? So that way you're standardizing it so that every single provider is basically doing the same exact thing, from the chief of the ED, the nurse practitioners, and everyone in between is basically working in the same exact model. Because that eliminates variation and makes sure that we're using the same evidence-based practices to ensure we're giving the same quality and consistent care to those patients. So, order sets can be a big way to do this. Having, kind of pathways built into your electronic medical records. This is all useful in order to ensure that consistency there. And so even if you have the most highly regarded means used to procure this evidence, so say double-blind placebo-controlled trial, it's important that you need to understand how we can apply this information back to your patients. And this is where things like meta-analyses can come into play, because you're using large swaths of research that looks at different types of patients and try to incorporate all of that into one final decision. So the first thing we'll talk about today is going to be Bayes' theorem. So does anyone remember what Bayes' theorem is? We kind of alluded to it previously. Really stuck to you guys, I can tell. I'll blame it on it being 8 o'clock in the morning. So Bayes' theorem is basically going to be saying, okay, so we have a test. We know what the sensitivity, the specificity of it is, but we saw that, especially yesterday, there's a lot of problems with things like, false positives. Who knows, there's going to be false negatives that are popping up here. And so Bayes' theorem is basically using predetermined information, having a prior probability, saying that, okay, what's the incidence or the prevalence of this disease in this population, and then applying that to your test based on the fact that you know sensitivity and specificity. And based on that, you can have a better idea of whether or not your patient is actually going to have the disease in question if they have a positive test, right? So this is kind of relating back to your positive predictive value, saying that if my patient has a positive value, what is the likelihood they're going to have a test? So going back, and remember we were talking about that example several weeks ago, they're saying, okay, let's screen every single person about to get married for HIV, right? And we saw that the incidence of HIV in that population would be relatively low, and so we saw that false positives were pretty prevalent there. On the other hand, if we were to do this and say homeless patients in an area with a high incidence of HIV, what would happen to your proportion of false positives? It goes down because you have a lot higher prevalence of actual true positives that would be in that population. So think about the prior information you're having and applying that back to your test now to make a better decision about your patients. That way I know if I'm looking at a particular type of population that if I have a positive test, whether or not that's going to really mean they had the disease in question or not. So I'll show you some examples of that in just a second. So the Bayes' theorem is going to help us to do this. I am not going to make you guys figure out how to calculate all of that because that would be real mean, and it's real early. So I'm just going to go over basically the principles of how it's going to apply to you guys and how we can utilize this information in a more realistic way. But essentially, what you're going to be looking at here is that the variables are what's important to understand. So looking at where P is denoting the probability. And so what's the probability that if this test is positive, they're actually going to have the true diagnosis? So D plus means that the patient has the disease in question. D minus would mean that the patient does not have the disease. And then T plus would be that the test was positive, and T minus being the test was negative, right? So incorporating all that information and trying to figure out that if, yes, I have a positive patient, what's the probability they truly have the disease? So a lot of people just throw in the towel when we get to this point, right? They're like, that looks too complicated, I don't want to do this. But again, we already found out there's other ways we can look at positive predictive values. And again, if you ever see this is basically just using the idea of what's the prior prevalence, what's the population I'm looking at, what's the prevalence of disease, and applying that to the test that I'm looking at. So looking at the numerator, again, remember, go back to that 2x2 cell contingency table that we had where basically you had patients who either had a positive test result or negative test result, and then they had the disease or they didn't, right? So cell A would be those that had a positive test and truly had disease, or your true positives. And then you had your false positives, you had your false negatives, and then you have your true negatives, right? So go back into your previous slide set and you'll see what those variables are going to be. So anywho, here we're going to see that the numerator is going to be the true positive results, meaning that the probability of being in cell A is going to be equal to that prevalence times the sensitivity, okay? So our sensitivity of our test times the prevalence in the population will help us to give us what's going to be in that numerator there, right? The denominator is going to be consisting of, first, what's being described in cell A are those true positive results, and then the second of which is going to be describing the false positive results. And so basically, that's going to be the true positive results divided by the true positive plus the false positive is going to give you this value here as A divided by A plus B, and basically that's going to be the positive predictive value. Okay, so that's essentially what we're trying to get to, saying that based on the prevalence here, if my patient has a true positive result, what's the likelihood that they're actually going to have the true disease there? Okay, so don't get lost in the variables or how to actually calculate. Just realize that this is what the test is telling us. So, for example, in genetics, a simple appearing formula for Bayes' theorem is being used. The numerator will be the same, but denominator can just be, the probability for the test being positive. So you may see some of these tests being done a little bit differently, depending on which what type of test you're looking at. So let's say we're going to be looking at using Bayes' theorem in relation to like a community screening program. So say, like, for instance, you're looking at initiating HIV screening before marriage, or if you're looking at TB testing for homeless patients in a given population, whatever it happens to be. But we know that in a population with a low prevalence of a particular disease, you're more likely to end up having that the positive results you're going to be getting, you're going to have a high proportion of those being false positives, right? We just know that because no test is going to be 100% positive or 100% sensitive and specific, we're always going to have those false positive results pop up. And so, although the fact does not automatically invalidate the screening program, it does raise those concerns about cost effectiveness. Because again, if I have a positive test result in this initial screening, what do I need to do with those people?
Send them on for more testing.
Probably for more testing, right? Potentially, depending on the test, maybe say, all right, let's go ahead and put you on treatment and then do follow-up testing or whatever happens to be. But yeah, so you worry about the cost effectiveness of that, right? So if I'm looking at, if you go back to that HIV screening sample or the example for those patients getting married, you saw a huge number of false positives, and then if you had to go on and subject all those false positives to getting, say, like a Western blot done or something like that, you see how the cost can go up pretty significantly there, right? So this is why using the prior prevalence based on things like census data or based on previous registries and things like that helps us to give a better idea of who we can target for these tests. So another example here would be like a tuberculin tine test for children. So this is kind of an older way that we would test for TB and for these patients. Basically, you'd have a small amount of this tuberculin antigen on the tips of these little prongs or tines. Basically, just pierce the skin, and then 48 hours later, you come back and see if there's any kind of area of induration there that developed. And so here, if the sensitivity and specificity of the test, and we had the prior prevalence of tuberculosis in the community are going to be known, at that point you can start to use Bayes' theorem to predict what proportion of children who have a positive test result actually have tuberculosis, right? And so this will give us a better idea of what percentage of those patients that come back positive say, yes, you do have disease. So, clinicians involved in a lot of community health programs, especially if you're working in kind of underserved areas or working like departments of health and things like that, can develop these tables that will list different levels of test sensitivity, specificity, and then also the disease prevalence. And so this is going to show these levels, how they're affecting the proportion of positive results that are likely to be those true positives. Again, always involving the prevalence here. And so the calculation is going to be pretty straightforward and useful, but it may not be used oftentimes in the early stages of planning for these screening programs. And so before a new test is going to be used, it's best to apply the test sensitivity and specificity, which again you're testing for before you would apply it to a large population. You like to figure out what it's going to be with the prevalence in that population to try to get an idea of your expected true positive results. And so this kind of helps to avoid some of those kind of awkward surprises of saying like, wow, 1,000 people tested positive for this. This is way more prevalent than what I thought. Really, you can go back and say, well, no, these are probably a lot of false positive results that are showing here. So the next table will show how the calculations can be made. Again, I'm not going to ask you to do those calculations, but just see how it goes into it. And so let's say we have a test that has a sensitivity of 96% and a specificity of 94%. That sounds like a pretty good test, right? Should be able to detect people who truly have disease and should be able to correctly identify people who don't have the disease. Sounds pretty good. And let's say we have the prevalence of TB in a community is only 1%. And then you'll see that 13.9% we do the calculations of those with a positive test result are actually to be likely infected with TB. So I'll show you how that works. So again, here you can see what our sensitivity for the tuberculin tine test is going to be, so say 96%. Because remember, when you're looking at your sensitivity, if you add that to your false negative error rate, that's going to equal 1. So and again, we have here 4%, so that makes sense based on what we talked about yesterday, right? Absolutely. Looking at the specificity of the test, right, so that would be 94%, so we said that. And then the false positive error rate, if you add that to the sensitivity or specificity, you get 1 as well. So that would make sense here. And then we know the prior prevalence. So if you were to plug that all into your Bayes' theorem, you end up coming up with this value that's about 13.9%. So imagine if you were to do this with, say, 10,000 children that you were testing in this study, okay? You would say that, all right, well, the positive test results I would expect to get based on the prevalence is 1%. So to get, basically 96 of those patients would end up being correctly identified. Meaning you'd have this many false negatives here, about 4. And then here for the non-disease individuals, because again, you would know 99% of those individuals should have no disease. And we know what our false positive error rate is going to be. So again, we have here 6% or 594 patients. And then the rest of them are going to be those true negatives there in that cell D. So essentially, what we're saying here is that we're having quite a few more individuals being incorrectly identified as having TB than we are having actual true positives, right? Because these would be all your patients here who are getting tested positive, that 96 plus the 594. So very, very low chance you'd actually be finding those true positive test results out of that whole group of people testing positive, right? So that's why we'd see a positive predictive value of about 14%, saying that if you do test positive, the chances you actually having it are only around 14%. So does that sound like a pretty good test? Not great, right? You're going to incorrectly think a lot of people have TB. All of a sudden, they're going to think they're infectious and they're going to freak out. It's not real good. Again, by correctly identifying your population, maybe looking for somewhere where it's more prevalent, you can limit how many of those false positives you end up collecting. So again, the first time a previously unscreened population is going to be screened, going in, you're going to have a considerable number of cases which may be found, which may be true or not. And then oftentimes you're going to have repeat screening programs done afterwards. You may find relatively a few cases of new disease, right? So this is because the first screening oftentimes is going to be collecting all of those prevalent cases that are found, right? So patients who already have the disease at the time of testing, they would already have that would be their prevalence. However, on the other hand, if you were to do a second screening, since you already have all those people who have tested positive, you'd be able to determine new incident cases as you move forward. So that's why you end up seeing, the first time you do a screening, you may have a ton of positive results. The second time, you may not find quite as many because of the fact you're now picking up just new incident cases. That kind of makes sense? Okay. So let's say, suppose a clinician is, how can we apply Bayes' theorem back to individual patient care, right? That's what you guys will be more probably involved with from the day-to-day. So let's suppose a clinician's uncertain about a patient's diagnosis. Let's say they get a positive test result for a certain disease, bless you. So we'll see how that works out. So even if the clinician knows the sensitivity and specificity of the test, doesn't really help you solve your problem, especially when you're only looking at an N of 1, right? So in order to calculate that positive predictive value, it's necessary to know the prevalence of disease in your community prior to applying that test to that patient to determine what they actually have. So in the clinical setting, that prevalence can be considered to be the expected prevalence in the population for which a patient is a part. And so this is information that may be collected by the Department of Health. For your local community, it could be information collected by CDC or lots of different places. And so again, the actual prevalence is usually going to be unknown, but usually a reasonable estimate can be made. Because again, you're never going to be able to 100% capture all of your population that may be at risk, but you can at least get a decent estimate. So let's say a clinician in a general medicine clinic is seeing a male patient who's complaining about easy fatigability, has a history of kidney stones. Okay, he has no other symptoms or signs of parathyroid disease on a physical examination. And so we're going to consider that the probability of hyperparathyroidism and decide that is pretty low. And so maybe say perhaps 2%. So it's kind of going with your pretest probability that you think, 2% chance that this guy actually has the disease. So again, this is your prior probability reflecting the fact that it's going to be estimated before you're actually performing any test, right? And this is kind of your clinical gestalt. It could be based on community trends in disease and things like that. But you're kind of saying this is how much I think it's likely that this person actually has this kind of disease state. For me, looking from a tox perspective, when we're doing things like doing consults for patients who are in the emergency department for, say, like an unknown ingestion, right? It's a very diagnostically difficult thing to diagnose because very frequently you're unable to get actual drug levels for many of the drugs that people overdose on, right? So say, for instance, I have someone who comes in and they are tachycardic, they're hyperthermic, they are agitated, they're biting people, have to be chemically sedated. And so I'm thinking, okay, what are the likely ingestions that could have caused this, right? And so something like, say a benzodiazepine overdose, like on Xanax, is that high probability or pretty low probability? Right, so I can say that sounds like a pretty low probability that this is actually what's causing the problem. And so then if I get a positive test result on a urine drug screen that comes back positive for benzodiazepines, does that really help me a whole lot? No, because the patient's not presenting like a benzo overdose. He's presenting like something else, right? So you get these ideas in your head going in, like, this is what I think the patient has going on. Here's kind of my probabilities, even if you're kind of just making them based on your own kind of clinical gestalt there, right? So kind of think about it like that. The probability, again, is going to be that prior probability going in before you actually run the test. So although the clinician believes that the probability of hyperparathyroidism is going to be low, he or she orders a serum calcium just to rule out the diagnosis, right? And so this is where you want to spin to rule things in. So you want sensitivity to rule things in, and then you want snout, or you want specificity to rule things out. I'm sorry, specificity to rule things in, sensitivity to rule things out, right? So again, you want to be able to use tests with high specificity to rule things in, things with high sensitivity to rule things out. Okay, so again, to the clinician's surprise, you end up having a calcium level that comes back of 12.2 milligrams per deciliter. So is it high, low, normal? Yep, sounds high, right? So then at that point, the clinician could order more tests for parathyroid disease. Some tests might come back positive, some might come back negative. So how can we use this positive test result to decide, make us have a better idea of whether or not, the probability this guy actually has the true disease? So Bayes' theorem can help us to interpret this positive test result. It gives you a little bit better way to interpret it rather than just kind of going off the hip and just ordering a bunch of tests afterwards. So a second estimate of disease probability in this patient can be calculated now, because now that we have the test result, we can look at the posterior probability, right? So this is going to be reflecting the fact that it's going to be made after the test results are known. We have this value back. How can we interpret it? So the calculation of the posterior probability is based on the sensitivity and specificity of the test being performed and that prior probability of disease before the test was done. So again, instead of using prevalence here, we're using our prior probability, or what we thought the chances were the patient actually having disease going in. So in this case, it would be about 2%. So let's say that the serum calcium test had a 90% sensitivity, 95% specificity, which implies that it has a false positive error rate of 5%, right? That kind of makes sense based on that. So when the information is used in order to get the posterior probability, you end up having a value of 27% when you calculate that out. And so this means that the patient is now in a group of patients with a substantial possibility, but still far from actually having a true certainty of having parathyroid disease. So I'll show you on a 2x2 table where you can get that 27%, how we calculated that. And so again, this is going to be identical to how we calculate this with Bayes' theorem, is identical to how you calculate with positive predictive values. So again, looking here at the test, you see that the sensitivity of the first test is going to be 90%, specificity is going to be 95%, so we know that our false positive error rate is going to be 5% there, and the prior probability of disease is 2. Okay, so when you end up putting that all the way through, you end up seeing that you have a positive predictive value of around 27%. So again, because that patient had a positive test based on my prior probability, I'm about 27% sure that this patient could have hyperparathyroidism, right? So at that point, you can start to make a better decision. Like, okay, well, what kind of test should I order? How can I go from here? What kind of imaging or diagnostic should I be doing in order to help further investigate this? So in light of 27% posterior probability, the clinician decides to order a serum parathyroid hormone concentration test while simultaneously measuring the serum calcium. So why wouldn't I have done that in the first place?
It's expensive.
Right, it's expensive, and if the patient had a low probability of actually having the disease beforehand, there'd be wasted costs basically. So again, because of that, the parathyroid hormone test had a sensitivity of 95% and specificity of 98%. The results turned out to be positive. You can then use Bayes' theorem again in order to calculate the probability of having parathyroid hormone. So again, now that you have kind of a new prior probability, you can use that to apply to the next test in order to get a better idea of what the patient might actually have. So and here, the posterior probability for the first test was 27%, right? So that was our probability that we think the patient has disease. Now we can use that as our prior probability for the second test. Does that make sense why we use that? Right. So now the result, the calculation for the new probability is going to be 94% based on the result that we have. Okay, so I'll show you how that works. So if we were to say that the second test, or looking at the parathyroid hormone level, was 95% sensitive, 98% specific, and then we have our prior probability here, you end up having it calculated out to meaning 94%. So now, how sure are you the patient has disease? Pretty sure, right? So again, using one test to kind of help to rule things out, and then now you're using another second test to rule things in at this point. And so again, in the first place, if you'd had a very, very low post-test probability in the first test, say, especially if you had like a normal serum calcium level, you could say, well, I probably don't need to do further workup. right? But using these tests in sequential manner, you can get a better idea of the percentages. So why did the posterior probability increase so much at the second time? One reason for it is because that prior probability was considerably higher for the second running of the test. So again, 27 versus 2%, right? And then another reason for it is because that specificity of the second test was assumed to be quite high, right? So in order to rule those things in for the kind of the second, the more confirmatory testing, you want to have something with a high specificity. So again, in that test, it was 98%. So if you had a normal parathyroid hormone level, that probably would have meant that he didn't have disease, right? So it has high specificity. So it has a markedly reduced false positive error rate, and this increased the positive predictive value pretty significantly. And so again, highly specific tests are used to rule in disease. So you start with things that are high sensitivity, and then you move to something with high specificity. Everyone with me so far? So looking at the influencing of the sequences of testing with an increased number of diagnostic tests that are available, need to consider whether to do many tests simultaneously or to do them sequentially. So again, tests used to rule out a diagnosis should have high sensitivity. Tests used to rule in should have high specificity, right? So again, you can do initial screening tests to see, if your patient is potentially, having issues with a particular disease, and then you can follow up tests afterwards, right? Doing them all at the same time could save you time, but it could also be very expensive, right? So you have to consider, healthcare costs and things like that, and also there's just the severity of your patient. So obviously, if a patient comes in is very septic and very sick, I'm more likely to need that time, and so I'm going to probably do a lot more tests all at the same time just to determine what's going on with them. So the sequential approach is best going to be done with starting with the most sensitive tests and then continuing to increase specific tests if the previous one yields a positive result, right? So then at that point, once you have a negative result, then you can kind of stop testing based on what you're seeing. So by sequentially testing, it's going to be more conservative and more economical in the care of outpatients, especially those with kind of more less severe disease or things that are not quite as debilitating. And so it may also increase the length of stay for hospitalized patients. So cost implications can be kind of unclear here, right? So maybe quicker. You may have, say, for instance, going from the ER perspective, it may be easier just to do ordering a couple of extra tests all at the same time in order to decrease your length of stay in the ER in order to see more patients, right? So you have to kind of consider the economical cost-benefit analysis there for ordering more tests versus how many patients can you see in the ED in that day. So something to think about. So you can also have overall implications for the overall accuracy. So if multiple diagnostic tests are performed at the same time, there's a natural tendency to try to ignore the negative results while seriously considering the positive results. So again, going back to my example where a lot of patients who appear to be intoxicated, a lot of providers get urine drug screens. And so all of a sudden something comes back positive for THC or benzodiazepines, they're like, yep, that's what's causing it. And I'm like, you may want to hold on a sec, right? Because if things are negative, you automatically discount them, right? And you may not consider all aspects of the test and what the implications that may actually mean. So, so even if tests are performed simultaneously, it's best to first consider the results of the most sensitive test and then move on from there to start to evaluate more of the specific test after that. So if a negative result is reported for that test, it's probably going to be a true negative. Patient probably does not have disease because we know that it's much more likely to have a true negative for a lot of tests than you would have to have a false positive. And then your highly sensitive tests are going to be more reliably positive when the disease is actually present and tend to deliver those negative results when the disease is absent. So again, start with the highly sensitive tests. If those are negative, then you probably don't need to go a whole lot further than that. And so again, by simultaneously testing, you're going to be producing conflicting results. So very, very frequent that you'll have something that are contradictory results that you're looking at, and it makes it more difficult to try to figure out what to do with your patient. And so careful consideration of each test result in light of the test sensitivity and specificity should improve the chances of making a correct diagnosis, right? So kind of evaluating them sequentially, even if they're all done at the same time, can be useful to try to make a better diagnosis. So with your decision analysis, the purpose is to improve the decision making under conditions of uncertainty, because again, you're never going to know fully what's going on with your patient. But in clinical medicine, it can be used on individuals, or you could use it for potentially general classes of patients. As a technique, the decision analysis is going to be more popular clinically than you would see with something like Bayes' theorem, right? Because again, very frequently, when you get a result back for a CBC, how often do you see the sensitivity and specificity being put on for all those values? Yeah, you don't actually end up seeing that very frequently. So hopefully a lot of this is done kind of on the background to give you a little bit better idea. Again, looking at where you set those cut points for abnormal values can be really important in setting your sensitivity and specificity as well. So hopefully a lot of that work's already been done in the background, so that when you see an abnormal result, you can be pretty sure that it's truly abnormal. So, being used with increasing frequency in the literature, especially to make judgments about classes of patients or clinical problems. This is very useful for helping you to make better decisions in broad terms, and then apply that to a general patient. So, for instance, getting a rapid strep test, right? So, if I get a rapid strep test that comes back positive, I'm going to have a pretty good idea that I'm going to go ahead and treat that patient with amoxicillin, right? Even though that may not necessarily be the best drug, I don't have my resistances back yet, but based on the probabilities, that patient is going to benefit from getting that amoxicillin to help prevent acute rheumatic fever, right? So things like that can be very useful in order to have that decision analysis there, so you can say, okay, this test came back positive, I'm going to go ahead and treat based on that. So primary value of decision analysis to help you understand that the kinds of data that go into a clinical decision, the sequence of decisions that should be made, and then the personal values of the patients that need to be considered before any major decisions are being made there. Because of course all these things need to be considered and talked about with your patients to make sure they're on board as well. This is going to tend to be more important as a tool to help the clinicians make disciplined approach to decision making, rather than making things kind of off the hip, evaluating just a single test and making decisions off of that. This is going to help you make better, more consistent clinical decisions for your patients. So 5 logical steps to setting up this decision tree. So 1, you want to identify and set the limits to the problem, then diagram the options, obtain information concerning each option, compare the utility values of those, and then perform sensitivity analysis. Okay, and so a lot of times you're going to see these being put in the literature where they've kind of run through these decision trees, they've developed these, and they test how well it's going to work for their patient group, and then you decide whether you can apply it to your patients as well. So when identifying a course of clinical action, you have to determine the possible alternative clinical decisions, obviously, and then the sequence in which those decisions need to be made, and then look at the possible patient outcomes for each decision. So again, if I decide to give antibiotics or not, did the patient get worse or not, right? So you're basically just doing this nice tree kind of pathway in order to determine how you're going to be treating that patient. And so clinical problem illustrated here is going to be whether or not to remove a gallbladder in a patient with silent gallstones. Okay, so that'll be our example we're going to look at. So first you're going to diagram the options. So the beginning point of the decision tree is going to be the patient's current clinical status, right? So you're going to have these decision nodes where these are defined as points where their clinician have to make a decision, and they're typically represented by squares or rectangles. And then you have chance nodes. So these would be defined as points where clinicians have to wait and see the outcomes. So you might see these being represented as circles. Time typically goes from left to right for these. Sometimes you'll see them go kind of from top to bottom. So I've seen some decision trees being done. And then the first decision typically set at the left, and then subsequent decisions are going to be, again, progressively more to the right. And so the beginning point is going to be the presence of an asymptomatic gallbladder in this situation. The primary decision node is whether to operate immediately or to wait. All right, so how do we decide whether or not we're going to do surgery or wait? So again, we have someone who's coming in, they're still asymptomatic, we know they have these gallstones, and now we have our decision node, right? So we're going to say, what's our operating, should we go ahead and operate now, or should we go ahead and wait? Okay, so then at that point, we have this chance node. We're saying, okay, what are the chances of the patient actually developing one of these symptoms at this point, right? So you can see at this point, if you're waiting, what are the probability of death is also being listed out here, right? So if you operate now, the probability of you actually doing the operation is 100%, right? Because you decide to operate. You'll see the probability of death is say 0.4%. Okay, pretty low, right? But what would happen if you ended up waiting? And so based on the chance node, you can see how things might go into different rates, go into different courses. So they may remain asymptomatic. You'll see a large percentage of those patients will do that. Some will go to have biliary pain. Some will go to have other complications, which are usually defined. And then maybe some will go to have cancer. Okay, and cancer obviously having the highest probability of death there. So we'll kind of go more into details as we talk about these. But basically, you're just basically having this chance node where you're trying to figure out which way your patient's going to go, and you have to wait until they kind of present one way or the other. So the probability of each possible outcome has to be obtained from, say, published studies or be estimated based on your clinical experience. So say, for instance, if you're looking at decisions about antibiotics, you have to look at local resistance patterns, look at your hospital antibiogram and things like that. And so, in this case, if the clinician waits rather than operating, the probability is 81.5% that the patient will remain asymptomatic. So pretty high likelihood they would remain asymptomatic. 15% of the patients will have periodic biliary pain. 3% of the patients will develop complications such as, say, acute cholecystitis or common duct obstructions. And then 0.5% of those patients will eventually develop a cancer of the gallbladder. Again, so this is data you're either collecting from your institution or collecting from the literature that's available. And so the probabilities of the possible outcomes for a chance node always have to equal 100%, right? Because the patient's going to have one of those things occur, and so it's 100% one of those will occur. So how do you divide those probabilities? So the utility of each final outcome also should be obtained. So in decision analysis, utility is going to be used to mean a value of a chosen course of action. So utility can be expressed as a desirable outcome. So it could be years of disease-free survival, in which case larger values would indicate greater utility, right? Because you probably want your patients to live longer. And then utility should be expressed as an undesirable outcome as well. So in this case, when we were looking at the gallbladder situation, death was listed here. So smaller values probably have greater utility, right? Generally don't want to kill your patients most of the time. Unless I guess you work in Oregon or something and they ask you to, right? Hey, don't do that. So clinical decision analysis seeks to show which clinical decision is going to maximize utility for your patient and or potentially minimize risks. So in the decision tree, each final outcome is going to be expressed in terms of a negative utility. So in this case, we were looking at possibility of death. We saw that surgery, if we went ahead and performed it now, the probability of death is going to be 0.4%. It's pretty low. If the surgeon waits and the patient remains asymptomatic for life, the probability of a gallbladder-related death is 0%. Okay. And then the probabilities of death for biliary pain, complications, and cancer are going to be 0.4, 10, and 100%. Okay, so using this information, we're going to be able to determine kind of what decisions should we make for these patients. So the decision tree shows that one choice is going to be clearly preferable to any other. Say there's strong evidence in favor of that choice. That makes it pretty clear for you. Often the decision analysis gives two or more outcomes with similar utilities. And so oftentimes you may either need better data to make a better decision, or you may have factors other than just what's included in the decision analysis that should be used for making that clinical decision. So maybe you need to look at things like your comorbid conditions for your patients. Maybe that makes surgery more risky for them. Perhaps they're having some other issues that would make waiting better. It just depends on other factors. And so in addition to comparing those utility values, then it's also sometimes helpful to perform a sensitivity analysis as well. And so these can be done to see if the results of the analysis are fairly stable over a range of assumptions. So again, looking at several types of patients perhaps and seeing if these values end up staying kind of similar over time. And they might consist of estimating probabilities of occurrence of a particular outcome at various points in the decision tree to see how the overall outcome in clinical decisions could be affected by different changes. So again, this is going to help the clinician and patient to see which assumptions and decisions are going to have the largest impact on their outcomes and a reasonable range of values, right? And so this can be a decision tree that's kind of shared with the patient and say, well, here are the possibilities, here are the options, which, have that decision or that conversation, say, which one might work best for you. So in the decision tree, we saw there was the decision node of either operate now or wait, and then we saw that probability of death from operating immediately, right, is immediately going to be 0.4%. So there are 4 different probabilities of death from waiting, and we saw how it's very, very low if they remain asymptomatic, all the way up to 100% likelihood, say if they had gallbladder cancer. So before the utility of operating now versus waiting can be really compared, it's necessary to average out the data associated with the 4 possible outcomes of waiting, right? So the probability of each outcome from waiting is going to be multiplied by the probability of death that would ensue following that particular outcome. Again, so looking at the likelihood the patient will go one of those particular routes and then multiplying that by the likelihood of death there. So for this circumstance, by averaging those out, you'd see that we'd multiply that 0.815, or because 81.5% of those patients would be asymptomatic, times 0, plus all the other values weighted out. And so at that point, what you end up getting is going to be 0.009, which is just a little over twice the risk of operating now. Okay, so now we can start to compare the utility of one versus the other, of waiting versus going to surgery based on that. So based on previous calculations, the best option would seem to go ahead and operate now, because we looked at the two outcome probabilities and they're fairly close. So looking at 0.004% versus 0.009, the difference is only about 0.5% difference there, right? Which would be 1 in 200 cases where that might actually make a difference there. So again, just based on this, the decision analysis does not strongly lead to one versus the other. Again, they're still pretty similar. But say you introduce a new assumption, say values change over time, or say you have a new surgery technique that lowers the risk of death, or something else like that, that can start to change the weights of those averages and may lean towards one or the other. And so again, by performing the sensitivity analysis, you can make sure to see if the same conclusion is going to remain for wide ranges of data assumptions, in which case you can remain relatively confident in those decisions. If small changes in the data or change the direction of the decision, probably not going to be super helpful. It means it's not very stable, meaning that even small changes in your assumptions can lead to big changes in whether those decisions are going to be kind of equally stacked. So obviously factors other than probability of death influence patient preference in the real world, right? So not everyone wants to go to have surgery. Most of the deaths that occur from surgery would end up occurring immediately, versus some of the ones in the chance node we end up having to wait kind of a long time, right? Like when might the cancer actually occur? Could be years, right? So deaths caused by cancer of the gallbladder or other complications would likely be very, very much later. And so many people would end up choosing avoiding immediate surgery, and would prefer to deal with complications if and when they arise, to have a considerable risk of death. So again, you may say, I want to take my chances with having the cancer pop up because I may only have 10 years to live anyway, right? Especially with older patients or something like that. So someone else who was willing to risk everything for the sake of a cure might express a preference for the most aggressive treatment possible. But it's important to make sure that they're aware of those kind of decision trees in order to help them make an appropriate decision as well, and you kind of interpreting along the way. So other decision trees can have multiple decision nodes that involve complicated issues. So that was a kind of a very simple kind of decision tree, but they can get much more complicated than that. And then they need to be reassessed and redone as time passes and new data and assumptions are going to be arising there, because again, medicine's constantly changing. In the more complex decision analyses, the objective is to find those decisions that are clearly less satisfactory and try to prune those branches. So you can find one that really just is weighted kind of poorly, doesn't really have any real utility. You can just remove that from your decision tree altogether to make things a little bit more simple. And so the idea of this choosing the best branch at each decision node, working backward, is called folding back. That's kind of a technique there. And then these trees are really only used in problems that do not have a repetitive outcome. So for instance, recurring embolic strokes in patients with atrial fibrillation, that might be a good one to use there. And so such problems can be better evaluated with Markov models or these Monte Carlo simulations. Have you guys ever heard of those? Basically, you take large sets of data and try to run them through a computer to simulate even larger patient sets to come up with probabilities. It's kind of beyond the scope of this class, but if you ever see reference to those, that's kind of what they're doing. They're kind of simulated studies in a way to come up with probabilities. So anyway, so decision trees are going to be increasingly being applied to public health problems as well, because again, when you're trying to decide health decisions for large populations of people, this can be very useful to make things consistent. If you're considering a strategy that would be most cost effective, say for eliminating a problem of hepatitis B, you could use a decision analysis tree to look at several options. So one would be, say, no routine hepatitis B vaccination. One would be a screening program followed by hepatitis B vaccination for people who meet certain criteria. And then say if you have hepatitis B vaccination for specific populations. So looking at, say, newborns, 10-year-olds, high-risk adults, and then, say, the general adult population of the U.S. So you might see those more often as you review the literature as you move forward in your career, so just keep an eye out for those. The last thing we'll talk about is going to be these meta-analyses. So we talked about a meta-analysis, and what is that? Here's some whispers. So taking lots of different research articles and research sources of data and applying them all together to try to come up with a clear decision. So again, I mentioned the Cochrane Review database is going to be one of the big ones you'll see very frequently that comes up. But essentially, it's a collection of related methods used to combine data from multiple similar studies to best estimate the effect of a medical intervention, right? So we use these very frequently. These are good for checking out research questions and things that pop up, especially if you're on rotations and your preceptor's like, should I do this or should we do this? What does the evidence say? A lot of times meta-analyses can provide good answers to these questions. So their techniques usually going to be applied to the synthesis of several randomized clinical trials. Sometimes you'll see, especially if the data is kind of limited, you might use case control studies, you might use cohort studies, whatever it happens to be. But frequently you'll see randomized controlled trials are going to be best to incorporate here because they have the best kind of strength of evidence, as we mentioned previously. Oftentimes multiple studies of the same intervention without any one study having a large sample size. So again, if it's you have a lot of small studies that are being done with the same intervention, those can be useful to pool together because then you now have kind of a simulated larger N to work with. And then again, these allow for the pooling of results of many different trials. So even if they have different interventions, say you were looking at the utility of giving ACE inhibitors for prevention of, say, diabetic nephropathy, right? So you may look at one study that uses ramipril, another one that uses lisinopril, one that uses a different dose of lisinopril. It's still possible to synthesize those different studies together in order to come up with an answer. So meta-analysis has many critics for sure, so there could be some skepticism that's reinforced by discrepancies between some meta-analyses and the large randomized controlled trials looking at the same questions. There can be concerns of the selections of the studies to be used. There's issues with the quality of the study design and the execution, right? So I could have, say 10 studies that are looking at, say the ACE inhibitors for diabetic nephropathy prevention, and if one study is really, really poorly done, and I don't take that into account, it could be skewing my data one way or the other. So there is a very strict kind of methodologic development that's continued to use to evaluate all these different sources of data to make sure that they're all going to be rigorously tested and try to incorporate them as best they can. So looking at one question, should studies in a meta-analysis be limited to those that are published? So like we mentioned with publication bias, a lot of negative results of studies are not going to be put out there. And so if the published literature were biased towards studies with positive results, then obviously synthesis of those studies would end up having bias towards a positive impact for the intervention. Unpublished studies are oftentimes going to have lower quality than the published studies frequently. Again, because a lot of times if you have negative results, it could have been an issue of, say, poor study design, or it could have been not powered to actually show a difference. And so unpublished studies are also going to be very difficult to find. Most of the time they're sitting on someone's hard drive somewhere and never getting out to anyone else. So some maintain that meta-analysis should be performed on raw data from many studies, but very frequently they're just looking at the actual published summaries of data. And so again, for instance, like if you were to look at my study with the coral snakes, like I did not put an actual huge Excel file that had every single patient from those 12 years of data that we looked at, because that's not going to be good for a journal, right? We ended up using kind of pooled data, and we ended up using summaries to put that information out there. And so some people would say, well, it'd be better if you could compare trials using all the raw data, but frequently that's not possible. So should studies be limited to just ones that are in peer-reviewed publications? Like that would be nice. At least you know that someone, an expert in the field, has at least reviewed the article prior. But again, peer review is going to be the primary method that we use for quality control in the medical publishing. Some recommend that only the studies that are published in peer-reviewed publications should be considered, and very frequently, especially with larger meta-analyses, especially Cochrane, they're much more likely to use those ones that are peer-reviewed because again, you know that at least had a critical eye on them to make sure they make sense. So, should they have any, should they meet additional quality control criteria? Very frequently you'll see where meta-analyses will actually summarize, what their inclusion and exclusion criteria were for different articles, right? So just like you would have inclusion criteria for patients into a study, people can do the same thing with articles into meta-analyses to make sure they at least meet some sort of rigor before adding them in. So again, it'd be nice if you have very good quality controlled studies. This helps to increase the internal validity when you do a meta-analysis, but just keep in mind that as you get more strict with which studies you include, you may decrease the external validity or the generalizability of that study to other people. So again, different investigators studying the same topic may use different criteria for what they consider to be a good study, and they may select different studies for the same meta-analysis. So just keep in mind what type of data they're looking at, what their inclusion are going to be for those. So is it acceptable to do meta-analyses of observational epidemiologic studies? Again, frequently quality control can be the big issue here. Case control studies usually cannot be combined with clinical trials because, again, it's hard to really compare, say, retrospective data with prospective data because they can't really show the same type of effect size, right? Because we can't do true risk ratios with retrospective data as we can with something prospective. Case control studies, case control methods are more useful if the outcome is relatively rare, because we mentioned the lower the actual prevalence of the outcome is in those case control studies, the closer it's going to estimate true risk if you'd done a prospective study. And so these methods have also been used to evaluate vaccines for uncommon diseases, things that are less costly and provide the results a little bit more quickly. So again, instead of doing the actual study yourself, this might be a little bit easier, quicker way to do that. Do the studies have to use the identical methods, treatment, dosages, patient characteristics, and durations of follow-up? That would be nice. It'd be nice if you could be able to use all the same methods, but frequently that's not going to be the case. And so again, this is where I mentioned that a lot of times the meta-analyses will look for tests of heterogeneity to see how different the articles are from one another based on their patient populations, based on the methods and intervention. So again, you may see a meta-analysis done with a high degree of heterogeneity. Some of the studies are very different from one another, and they'll list that in their limitations on the discussion of the article. But just be aware that there are tests for that to see how similar those studies are going to be. So there's two types of meta-analyses. You can see a pooled quantitative meta-analysis, and then there could be a methodological qualitative meta-analysis done as well. I'm just going to go ahead and finish this section, and then I'll give you guys a break, and we'll do the review. Is that okay? So the main purpose of meta-analysis is typically quantitative with these pooled meta-analyses, and so the goal is to help to try to get a better overall estimate of the amount of benefit achieved by a particular intervention. So this would be good if you had a lot of studies that had small patient populations. You had to kind of pool that data in order to get a better idea of what it would be like for a larger sample. Again, this is going to be done by combining or pooling estimations found for existing studies. So very frequently you'll have different studies based on their sample size. They'll have different weights applied to them, so that way you can kind of compare apples to apples when you pool all that data together. And so analysts pool the observations of many studies, calculate the parameters, things like risk ratios and odd ratios from the pooled data to come up with a new value that will hopefully be more representative of all those studies together. Because of many decisions regarding inclusion and exclusion of the studies, the meta-analyses might reach very different conclusions on the same topic. So just because Cochrane does one way, you might see someone from JAMA do a meta-analysis a different way. It's possible to have these different results that can occur. And so you can do a sensitivity analysis to look at the exclusion or exclusion of various studies to see what kind of effect they might have on the analysis. So say maybe if I'd included more studies that I originally excluded, how does that change my results to see how sensitive they are being to those outcomes? And so again, looking at things like the including or excluding studies of poor quality, or say ones that have been done by pharmaceutical companies to see what kind of effect they had. Because what are one of the potential biases with studies with pharmaceutical companies? That money, right? One of the big things I always tell people to look at in their studies is to see who funded it, because very frequently if you see nice positive results for a drug, see who funded it, because it's probably likely that the drug company might have had something to do with it. Not to say that those results are invalid, just be aware that it's a potential bias. And a lot of times that's the only way those studies are ever going to actually be done. So for instance, when I mentioned that Crofab study we were doing up in Jacksonville, comparing Crofab versus the new antivenom that they were comparing it to, that was being funded by the drug company, right? Because that was a clinical trial for that drug. So we as researchers were doing everything as appropriately as we can, but there still could be some degree of bias there, right? So again, if they came by and bought you a nice lunch and said, okay, let me just make sure the stats look good on this one, something to consider. Hopefully it should never happen, but you never know. So even after the studies are being chosen, there's going to be some methodological issues that can come up. So how do you choose to combine the means and variances from the different studies, because they're going to have variances there? And then what weighting methods should be used? Like I mentioned, different studies will be given different weights, and so that can be done by different calculations. They should be reporting relative risks and risk reductions, and then absolute risk and risk reductions. That should be some of the reporting that you see in those studies, especially if they're looking at randomized controlled trials. It's kind of a debate about the most appropriate way to pull the data, but just know that, for example, a meta-analysis is being done to look at the effect of a treatment with a particular antihypertensive, so we'll say drug A. We'll say the proponents of the fixed effects model of doing this would assume that there's only one true mean value for the effect of the drug, and that all study means represent estimates of this true mean. So they're just basically, tests are being done a little bit differently to try to show the same value. And so this assumption would end up permitting the pooling of values from all patients and several studies being considered. considered, right? So you end up having just taking that raw data, putting it all together, and coming up with a new mean value that would be valid. In contrast, some people would say, proponents of the random effects model would assume that each study is measuring its own unique effect, in which case you have to use more complex methods in order to incorporate that data together because there are all those inherent differences in the actual studies, right? Because you're looking at different patients, you're looking at different areas of the country potentially, all those kind of things. There's random effects that could be affecting that. The other way you could have this methodologic or qualitative meta-analysis, and sometimes the question to be answered is, is there any benefit at all, as opposed to how much benefit? So again, looking at something like hyperbaric oxygen for carbon monoxide poisoning, or for wound healing, or whatever it happens to be. Qualitative meta-analysis evaluates the quality of the research, and so they actually will have scored according to a list of objective criteria. You'll see a lot of Cochrane reviews being done like this. The meta-analysts will examine the methodological superior trials and determine whether or not the question of benefits is answered with a consistent direction. So the qualitative approach has been called methodologic analysis or quality scores analysis as well. And so in some cases, methodologically strongest studies are going to agree with one another and may disagree with weaker studies, because again, if you have a nice, well-populated study, you're going to be able to hopefully show differences that they really exist there. So a good example would be a meta-analysis showing the 8 major controlled trials of the BCG vaccine against tuberculosis. And so they found that only 3 trials met all or almost all of the criteria for a good study that they set out and had precise statistical estimates. So they all agree that the BCG vaccine afforded a high level of protection against TB. Okay. On the other hand, they saw that the remaining 5 studies were weaker and had large confidence intervals. Right. So large confidence intervals means what in the quality of the data?
It's not as tight.
Yeah, it's not as tight. It's very variable, right? So there's lots of variance in there. Again, usually a reflection of the population size or the sample size. So here, the conclusions varied from showing a weak protective efficacy to actual harm from the vaccine. So again, by being rigorous and looking at the quality of the studies included, they're able to find that okay, the large studies, the ones that we feel are the strongest evidence, show consistent effect. Another good example would be one that was in The Lancet, another good article or good journal out there. Meta-analysis of randomized controlled trials comparing coronary angioplasty with bypass surgery. So the source they were looking at was in the UK. So looking at the abstract, again, we don't want to judge articles just based off the abstract, but if we were to look at this, basically they said, okay, patients with severe angina will be eligible for either angioplasty or cardiac or bypass surgery. And so what they looked at was results from 8 published randomized trials. So they took 8 of the randomized trials that were published out there, combined them in a collaborative meta-analysis, right? So they're able to combine all these patients, and now they have a much larger sample size to pull from, roughly 3,300 patients. As you can see there, where they had 1,600 got CABG, 1,700 got had the angioplasty done. So and then they had a mean follow-up of 2.7 years. So again, all the studies may have, one might have been 1 year, one might have been 3 years, but they averaged them together to get roughly 2.7 years. So again, you can look at the results here, and then if you go down to the next underlined section, you can see that overall there's substantial similarity in the outcome across trials. Right, so that's one of the big things they look at to see did all the trials show a similar effect. Going down, the combined evidence comparing angioplasty with CABG shows no difference in prognosis between the 2 initial revascularization strategies. However, treatments differ markedly in subsequent requirement for additional revascularization and relief of angina. And so they basically were saying that the results will influence the choice of revascularization procedure in future patients with an angina. So again, they're saying that yes, either one probably was roughly equal, but then there was concerns with the revascularization in your patient's angina. So that's basically the whole point of the study, was to pull all that data together to see which one, if they truly had the similar effect, and what that means for your patients in the long term. So another one could be something like one in JAMA would be the effects of exercise on glycemic control and body mass and type 2 diabetes. Again, this is another meta-analysis of controlled clinical trials. And so here they're looking at the fact that a lot of these trials had small sample sizes and conflicting results. And so it's always very difficult, especially when you're out there trying to answer a question like, okay, well, what's best for my patient? And all you have are really small sample sizes to really compare with one another. And one says yes, one says no, one says who knows, we can't really tell. So it can be very difficult to make a decision here. So again, this is where meta-analyses can be useful. And here you can see how they'll have their data sources listed out. So let's say like which resources they looked at, whether it was PubMed, whether it was here you can see they looked at the Cochrane Controlled Trials Register. Again, that's where a lot of those Cochrane reviews come from. And so they list out where their data sources are coming from. They list how they actually selected the studies. And so here you can see that selected studies evaluating the effects of exercise interventions with at least a duration of 8 weeks in adults with type 2 diabetes. So that's the studies they were looking for. And they found that 11 randomized, 3 non-randomized controlled trials were included. Studies that included drug co-interventions were excluded. So they have to be explicit about what they're including and excluding on here. So we want to get rid of all the effects of drugs that might be having on this and just look at exercise. And so then they do the data extraction. You'll notice here they had 2 reviewers, independently extracted baseline and post-intervention means. So then at that point, what do you have to worry about? Yeah, inter-observer variability there, right? So they may do something like give a kappa value that would say how good the agreement is between the 2 reviewers. Then they'll do the data synthesis where they actually combine all the information together and they end up coming up with a conclusion. So basically they said exercise training reduces A1C by an amount that should decrease the risk of diabetic complications, but no significantly greater change in body mass was found, blah, blah, blah. So again, by being able to pool those studies together, you come with a more consistent answer to say like, yeah, it probably helps with your A1C. So having one study say no, one study say yes, this gives you a better answer. Okay, another one would be postmenopausal hormonal replacement therapy. I did a review here. Again, they should be listing their data sources. They should be, again, if you look here, they're looking at all relevant English language studies. So what's one of the limitations there?
Could be other foreign studies that are better or more solid.
Yeah, so sometimes you'll have studies that might be in a different language, but of course if the researchers can't read them, probably not going to be super useful. Again, most articles that come out there, so especially you'd be surprised how many articles you read coming out of like Japan and China and Taiwan and all these different places end up getting translated over into English. So almost everything gets translated at some point. So that's kind of one benefit, that you don't really miss out on a lot of that data, fortunately. But again, here they're looking at the use of those the HRT and these postmenopausal women. See how they were able to select the studies and how they did the data extraction. So again, studies were excluded if the population was selected according to prior events or presence of conditions associated with higher risk for targeted outcomes. So if they already had uterine cancer, if they already had something like that was predisposing them, they were excluded, right? So that's kind of how they selected their studies. Went ahead and did all the data synthesis. Again, you should read all the details on that. But essentially, they come up with their benefits. Their pooled analysis say, okay, this is what we think the consistent answer is based on all these studies. Okay, so in summary, we talked about Bayes' theorem, how we can apply that to making better decisions, both on a community screening kind of scale and both in our individual patients. Again, using that either prevalence in the community for a disease to help us inform the post-test probability, and then also utilizing things like your pre-test probability in a individual patient based on what you think their risks are of having a true disease, and then using follow-up tests afterwards in order to determine whether or not you truly think they have it. And then we talked about the meta-analyses and different ways that those are utilized in the research. So any questions on this section?
For meta-analysis, because the studies themselves have their own inclusion and exclusion criteria, and then the analysis then itself has exclusion and inclusion criteria, doesn't that kind of affect the generalizability of the meta-analysis in general?
Yeah.
100%.
So you always have to look to see like what type of studies are actually including. And so sometimes you'll see where they're including studies based on the type of population they're looking at. So again, if you're looking at that the last one with the HRT therapy, they're excluding women who already had pre-existing conditions basically that would predispose them to having a new event. So again, that leaves you to not be able to generalize that information back to those type of patients. Again, so absolutely. So and hopefully the type of patients they're including are going to be consistent, and in some cases you may actually increase some of your generalizability if they take patients or take studies that have different varieties of patients, right? So then all of a sudden now you're including things where you may have a wider variety of people that now you can say, yes, we're still seeing a consistent effect here. Yeah. Any other questions? All right.